So, Bismillahirrahmanirrahim. Assalamu alaikum to you, sir. So, what I thought that previous two lectures would illuminate upon the management of CEO esophagus as such, and probably the speakers will be here to join us soon. But what I want to dwell upon is the procedure of esophagectomy and our experience at CMH Rawalpindi. So, ever since esophagectomy was first done in 1877 until now, surgeons have as yet to find out the most ideal method of doing an esophagectomy. And in their endeavor to do so, because it's a daunting procedure, and probably no other procedure you traverse the abdomen, the chest, and the neck at one time, in who is mostly a malnourished patient in our setup and an elderly one at that. So the results as far as the mortality and morbidity are concerned are consistently improving, but no ideal single method has yet been advocated. So people would do in an open approach and still doing an open approach because minimally invasive is being done by less than 10% or so. So I would do Ivor Lewis. I'm sure the audience here is well aware with all these techniques, or a transhiatal one, or a left thoracoabdominal, McKay one, and differing also into the extent of the lateral resection that needs to be done. So those who would advocate an Ivor Lewis would say, open the abdomen, do a laparotomy, make a tube, go into the right chest and do the anastomosis. Or mobilize in the chest and then turn the patient around and mobilize the stomach into the neck. Or just avoid a thoracotomy as Oringer would do, and with its own advantages, or a left thoracoabdominal approach. And each one citing almost similar advantages and disadvantages results, and people would mostly based upon their decision upon avoidance of a thoracotomy as in Oringer, so that you do away with the respiratory complications and the pain part of it. And those who, on the other hand, would do the anastomosis in the chest would say taking it into the neck would do recurrent laryngeal injury, anastomotic leakage, stricture formation, whatever. And the tumor location would also dictate. But at the end of the day, it remained the preference of the surgeon, the training that he had done, the institutional preferences, and people would adopt to, and rightly so, to one single technique. So as minimally access surgery came along, all these procedures like Ivor Lewis, transhiatal, free-stage, all could be done by minimal access approach, even robotics. So to compare, an open esophagectomy would be doing a laparotomy and a thoracotomy. A hybrid would be doing one part as a minimal access procedure and other part as an open procedure. For example, do laparoscopic mobilization of stomach, make a tube, go into the chest, do a thoracotomy, and then perform the procedure, complete the procedure. Or doing everything by a minimal access approach in the chest as well as in the abdomen. So in CMH Rawalpindi, we have passed through our phases of evolution. So once I joined in 2001, and the center was recognized for fellowship, and we were already trained general surgeons. So our mentor at that time, and we were sort of fixed upon doing the transhiatal approach. And to good evidence to that, and we were doing all right with occasional three-stage procedures and with the proposed advantages of avoiding a thoracotomy. And then after 8 years or so, then the regime, as it so happens in military, the regime changes, and then we went on to left thoracoabdominal approach, popularized mostly from our end, inspired by our KPK colleagues who do a large volume of esophageal resections, and then they would do a left thoracoabdominal approach. Since 2014, however, we thought that it's time to go ahead to do minimal access esophagectomies. And the main reason for that was to take all the advantages of minimal access and then to gather evidence that whether this is a feasible procedure or not. And this being the premier training center of Pakistan Armed Forces, we had to take the lead in any case as well. So, and obviously, from this maximally invasive surgery about 10-15 years ago, and the hand passing from the abdomen into the neck, to obvious cosmetic advantages at least of 3 ports in the chest and 4 or 5 ports in the abdomen, and this is all about. But the journey was not as simple as it may seem. The first of all, we needed to be, you see, myself at that already was 49 years old, and doing a prolonged procedure with laparoscope and everything takes a toll on the body with the ergonomics. But we were eager. We had a good team of registrars and OT staff and anesthesia. The volume was decent enough. We performed about, let's say, 50 to 70 esophagectomies a year. Clientele affordability, as far as this was concerned, the staplers cost. Professor Chima and everybody, I think, from Pakistan realizes that a certain part of our population is free to all treatment. So that was not a problem. But even our private patients, those who were told about the advantages, don't remember except one or two who could not arrange these things in the hope of having the advantages of minimal accessory. We could have prolonged working facility, which in a public sector hospital, I realize that it is sometimes very difficult. The large amount of workload and theater space availability, so you can't have very prolonged working facility. But we were blessed with that. And the post-op facilities had much improved by this time. But then there were decisions and there were questions to be answered. What type of case selection is to be there? Because in open cases that we used to do, we were a little adventurous, if I might add, so especially in the early phases of our training, you might say. And the availability of equipment was not that big a problem. The selection of the procedure was actually to do a transhiatal or a 3-stage or Iver-Lewis or whatever. And believe me, we did try everything. And I will develop on that later on. And then once you choose a procedure, like in all ecumenical access surgeries, the proper positioning, port placement, and re-recognition of the anatomy. You see, surgeons are used to looking at a certain anatomy. And once that is changed, they completely lose weight. And there were prolonged initial times, and anesthesia people have to be convinced and to be made aware that prolonged hypercarbia may cause respiratory acidosis, and we had a few cases. So we needed to sort out these problems. And once having tried all these procedures, hybrid procedure to start with, 2-stage, transhiatals, Iver-Lewis, in the end, the procedure which is favored in our department and which is being done is a VATS prone mobilization of the esophagus first, then turning the patient into Lloyd Davis position spine, and then proceeding onto stomach mobilization and anastomosis in the neck. And what we found out and what we advocate is that it provides an excellent exposure of the esophagus with ergonomic advantages, and thoracic phase can be done by a single surgeon solo. With decreased pulmonary mobility and decreased blood loss, and the blood which somewhat oozes goes into the dependent part and does not obstruct the field, and somehow decreased recurrent laryngeal nerve injury, and we don't find much anastomotic leaks now. Indications for malignant, and allow me in the Society of Surgeons for Cancer Surgery to add a few cases of benign disease as well, because I'm talking about minimally invasive esophagectomy, and they provide a part of the spectrum. So as in any case of esophageal resections, you need to build up the patient because they have had progressive dysphagia for some period of time, usually presenting late. But the situation is much better than what we started off with in 2001. People come earlier, but still they take about 2-3 months for the symptoms, their presentation, investigations, and coming to us. So those who would not require much preparation would be prepared on a TPN or feeding gymnostomy for 2 to 3 weeks. We don't really get fat, but the negative nitrogen balance converts to a positive nitrogen balance, and that would be more appropriate if you're taking such a big surgery. Special emphasis on pulmonary rehabilitation, detailed counseling, repeated hammering to them, giving them spirometry and everything, making sure that this patient does not go into respiratory complication, which actually is the major morbidity of this procedure, cardiac evaluation. But then comes the point of upfront versus pre-op neoadjuvant This is a contention. I'm sure Professor Amir Nisar would be here and many others would be here and from our Khan as well. And people with established protocols of preoperative chemo or chemo radiation therapy. And though we tried to do it and we tried to follow it in our multimodality meeting, but we were not having as good results as advocated by others. So not necessarily as to the difficulty of operation is concerned. Operation was all right, barring you expected few adhesions in surgery. But somehow their immunocompromised status, their nutritional status, and the results would be more complicated by non-surgical complications like pulmonary and septic complications. And we have come to sort of a protocol that we would only offer CCRT or chemotherapy to those patients who were younger, fitter enough, and would be able to tolerate some complications if they do it. But if there is an elderly patient with some comorbidities and a resectable tumor, then we would probably go for an upfront surgery because they, in our setup, they have not done well after pre or neoadjuvant therapy. Equipment instruments was not a problem. And now dwelling upon to the procedure, the anesthesia was tricky, positioning and procedure will go along. So anesthesia was in the prone position. We started off with having a single lung ventilation. With our hesitation that it's better that the lung should be collapsed, but we had problems with that. First of all, they would take more time to put in a double lumen tube confirmation, and once the position is changed, in few cases, it's dislodged. And to then readjust the tube in the prone position is very difficult. So after 100 cases or so, we have done away with double lumen tube, go on to lung ventilation, just ask them to reduce the tidal volume and insufflate about 8 millimeters of mercury carbon dioxide, and that provides adequate exposure. And we didn't have to actually convert or having exposure. Even if there are some adhesions, we take them down, and because the posterior upper esophagus, as it is in the view, which I will show you later, that is the only view that is required. So we had to educate, and they have to pass through a learning curve of long surgeries with hypothermias, hypocapnias, and we have passed through that stage. So this is how we make the position. The patient, after all monitoring and everything, is placed prone with a pillow under the chest and the buttocks, abdomen allowed to move free, hands taken forward so as to move the scapula forward so that we have an area in the chest. This was from a previous yesteryears once there was a double lumen tube. And these are our ports. So once the scapula is down or moved forwards, 3 ports, a camera port and 2 working ports are all that we actually needed to take in consideration. So a 10 mm port for our camera, a 30 degrees camera, 2 5 mm ports. This can be converted to 10 if you're putting in swabs and taking them out, or even or you're contemplating to clip the esophagus or something like that. So let's say 1 10 mm, 2 10 mm, and 1 5 mm port are all that is required. And then, as I will explain to you the procedure in the video, but then as you go along, this is the first view of what we get inside. The esophagus vein, esophagus in the groove, the lung in front, mobilization of the esophagus and its division, mobilization of the proximal esophagus over the trachea, the tumor along with the lymph nodes. This sling, we are not actually doing it anymore. I'm just trying retracting without my other grasper, but this is an old photo. Once mobilized the whole of the esophagus, then we close the ports, place a chest tube, turn the patient over, make him go into Lloyd Davis position, steep up with 5 ports. So the first port would be somewhere about 1/3 of the way from the xiphisternum to the umbilicus, or depending upon the physique of the patient, or maybe lower down. And 2 hypochondrial ports, the right one a little closer to the midline, assistant port, and a liver retractor port. Opening up the lesser sac, dividing the short gastric vessels, going on towards the pylorus, pars flaccida and the lesser omentum taken down, the left gastric vessels, their division, hiatal dissection, meeting with the mobilized part of the chest, esophagus, making an intracorporeal tube, and joining it with the stump to take up to the neck. This is one way of doing it. But if you have short of staplers or you think that you're just tight, so what you can do is go to the neck, divide the esophagus from there, pull out the stomach from the smallest of incisions, make a tube outside the abdomen, and take it into the neck. In the neck phase, it is an incision along the sternocleidomastoid, left, division of strap muscles, and then slinging of the esophagus. In the neck, the anastomosis that we are presently doing is a hand-swing anastomosis. It can be either with Vicryl, it can be a running one, or it can be interrupted. Not doing a stapled analysis right now. This seems to be working well for us. And this is the usual procedure that we do. Once we attempted upon transhiatal esophagectomies, we were able to do it, but then I came to the conclusion that this was more difficult, especially as far as the lymphadenectomy part of it was concerned. Especially the tumor was little higher than the hiatus, then I thought it would be somewhat precarious or dangerous to mobilize and take up the stomach. However, this is most routinely being done in patients who are having a total laryngopharyngectomy, in which we mobilize the stomach, make a tube and take it up with the neck. These patients have a virgin chest and the abdomen, so making a tunnel retroperitoneal posterior mediastinum is not that difficult. Ivor Lewis we did, but then we have not passed through our learning curve, and we are somehow still reluctant to perform our anastomosis in the chest. This is total laryngopharyngectomy, meaning the stomach has been mobilized by minimally invasive method, taken up into the neck. Corrosive strictures, I believe they are not part of it, but then they are more difficult problem as far as minimally invasive esophagectomy is concerned. Because of the extensive fibrosis, complex reconstructions, strictures at multiple sites, we will let go at this one. Few cases of motility disorders, 2 or 3, in which they failed treatment, recurrent operations, and ended up in having an esophagectomy by minimally excessive approach. Now I would like to share a new share. So we'll go on to the video. Yeah, can you see this video, sir? Picture?
अभी पिक्चर आ रही है, वीडियो चली नहीं है. Can
video,
you,
sir? Video. मैं कहता हूँ, sir. Video will run through. It's a little fast up for the to actually wrap up the proceedings. So this is the first view that you get. As I explained, the esophagus in the groove, the vertebrae with the intercostal veins, the lung fallen down, superior vena cava with the phrenic nerve over it. This is the vagus nerve, and this here is the edge of the tracheal rings actually. The hilum of the lung is here, and it has fallen forward. Inferior pulmonary ligament is here, and this is the diaphragm. This is the diaphragm contracting. Probably the patient is a little light at this point of time. So what we start is first of all the mobilization and division of the azygous fluid. Some people would not divide the azygous fluid, but we find that it is convenient and it is easier for the conduit to lie down smoothly in the posterior mediastinum. Tie it up, clip it up, or maybe do double if you are a little hesitant. After dividing the azygous, then we start to mobilize the esophagus. So one method of doing is to take a strip of pleura. So from the lung side of it, we start dividing the pleura. This is the inferior pulmonary ligament. So taking out of the hilum, this is the vagus nerve. We don't do a vagal sparing esophagectomy people want to do. Divide the vagus as such. This is the upper spine part of the pleura. or the edge of the pleura that we are now dividing, so as we can go all around the esophagus, going down towards the, uh, this is the upper part of the esophagus. In front of it is the trachea, and this is here I'm a little afraid because patient is on a single lumen tube, and if you make a nick in the trachea, it's very difficult to take control of the airway. So do it by hook, slowly and gradually, fiber by fiber. So once around the view that I would like to look at is from the above downwards, because now I can see the other edge of the esophagus from this side as well. So this is behind the esophagus, the tracheal ring, upper part of the esophagus. So if you do it fiber by fiber, then these vessels do not usually bleed much from the aortic side. This is the pericardial, this is the membranous part of the trachea as well. This one. So the esophagus has been taken off the trachea, which is divided into the right and the left main bronchus somewhere here. This is the distal part, and in this I found it is more useful to go as down as possible, probably into the abdomen, rather than taking that section from down and then persevering with it. Now that we are almost there, so this is the right and left crus, and we have mobilized right up into the abdomen. That makes the abdominal part of the dissection easier. So this is a tumor along with the lower part, the pericardium and the lower part of the tumor, and then there are lymph nodes in the subcarinal region and elsewhere, and they are taken or dissected alongside. And this lymphadenectomy is actually the major advantage of doing a good thoracoscopic approach. Now we go on to the abdominal phase. Having done the mobilization and placed the chest tube, turn the patient over. So we go on to the abdominal phase. So this here is the arcade, the pancreas, and we start making a window in the lesser sac. So the greater curvature is being mobilized, short gastric vessels. And here my trick of the procedure is to take it up to the hiatus, but I do not open the hiatus till very late or the end of the procedure, even after I have made the tube. Because I found out that we are going towards the pylorus now, this part of it. By not going into the hiatus, was what we started to do was, once we started to open the hiatus early in dissection, the gas would leak from the abdomen and go into the chest, into the right, the pleural cavity, or sometimes the left also. And we would have difficulty in carrying out the rest of the procedure. So this is going to the pylorus part and mobilizing as much as possible. And then we go on to the posterior regions over the pancreas that we are taking down. The stomach, because it has to go to the neck, has to be mobilized adequately. Right crus, left gastric vessels, lesser omentum being divided. The lymph nodes, you can appreciate, they have to be taken towards the specimen so as to have proper lymphadenectomy. So left gastric vessels are being mobilized. Vein and the artery, and the lymph nodes have gone up. Clip them, staple them, ligature them, whatever, but make sure that it's adequate hemostasis, because they tend to bleed a lot. And then remaining part of the posterior part of the stomach is mobilized. And then I stop there. Then I go on to make the stomach tube about 6 and 7 centimeters from the pylorus. The first stapler is passed. I usually do it from the epigastric port, from the umbilical port, and it's the second stapler. 4 to 5 centimeter conduit width is seemed appropriate. And in no part of the procedure, what we try to do is to handle the stomach, the tube part of it. We get an assessment and we turn it around, and we know that where to take off the last stapler, because that would take a pink healthy stomach into the chest. Last stapler and the tube now formed. Then I go into the hiatus part. So this is the right crus. Dividing the adhesions to the tumor. So this is now the free tumor, the small bit left here, to the left pleural cavity can be seen. And now we will sew the tube with a remnant so that it could be pulled up from the neck through the posterior mediastinum. So this is as far as the procedure is concerned. And then as a last, another video, it is only about Thursday, sir, that Wednesday night I got a call from my gastroenterology people that there's a soldier with a dysphagia, progressive dysphagia for the last 3 months. And they were doing an endoscopy for diagnosis, and they had a malignant protein structure and they tried to dilate it. And as usual, that there's a pneumoperitoneum and there is a surgical emphysema and there is a pneumomediastinum, and he has a perforation on the stomach or the abdominal part of it. So we saw the patient. The patient on that day was not septic. And considering it to be a tumor, which on a CT scan it was surely, and thinking that now what to do, whether to do a damage control surgery or go ahead, we did a minimally access esophageectomy on that patient. This is the third post-operative day. And as far as the advantages of the minimal access surgery, for that I need to show you another video, because this is the patient on the very first day, about 6 hours after the procedure. वीडियो नजर आ रही है आपको?
नहीं, आप वीडियो नहीं नजर आ रही, वीडियो आप नहीं नजर आ रही, आप जब स्टॉप शेयरिंग इट।
मैं करता हूं, देखिए।
I didn't want to interrupt you for enjoying the videos. We are running short of time. Actually, we have 4 speakers to cater for.
Okay, we'll stop at that. We'll stop sharing. And then and in the answer, I would just, but you want me to finish the presentation or we?
Actually, there are 4 speakers in this presentation, 15 minutes each. We have already gone to.
I stop at that. So thank you very much.
नहीं, आप उसे अपने concluding remarks तो दे ना हमें, concluding remarks दे, summary जिसे कहते हैं आप.
So summary ये है कि summary is कि minimally it is yet to be decided that minimally invasive esophagectomy is better over an open esophagectomy or not. इसकी randomized control trials are difficult. The best case scenario is that there are 2 trials going on, and they have proved that a hybrid esophagectomy, at least, if not a totally minimally invasive esophagectomy, is definitely better as far as 30-day and morbidity and mortality are concerned. Morbidity is concerned. I've lost your videos.
We can hear you, sir.
अच्छा, तो अब वो प्राइस तो आनी है, लेकिन as far as 30-day perioperative morbidity, especially respiratory complications are concerned, वो तो सर definitely better हैं. They have been proven. But it is a procedure to be taken up in specialized centers, specialized cares targeted. We need to have cares for them, and obviously time will tell whether this is a much improved procedure or not. Thank you very much.
Thank you very much. Over to Professor Haroon.
Sir, thank you very much. Thank you, sir. It was a brilliant presentation. We really learned a lot, and I think that you taught us a couple of tricks about minimal access surgery, especially regarding post placement and not opening the hiatus earlier on when you're doing abdominal part of the dissection. Thank you very much, sir. I think we'll, Dr. Huma is raising her hand, but we'll take the questions afterwards. I'd like to directly invite our next speaker, Dr. Ademola Adeyeye. He's a European board certified surgical oncologist based in Nigeria, and he's the surgical oncology lead over there. Dr. Ademola, please go ahead. It's all over to you. We can see your screen now. Thank you, sir.
Hello, good day, everybody.
Yeah, we can hear you.
Okay, I apologize once again for the technical difficulties earlier experienced.
I'll just request that you keep your presentation to 15 minutes because we have two more speakers following you.
Okay, don't worry. I'll do that. So we're talking about the management of gastric cancers in resource-limited settings have been introduced, so I won't take time on that. I have no disclosures, but I have to acknowledge a number of centers which contributed to my presentation, especially the University of Zurich and the Sloan-Kettering Cancer Center. So I'll quickly follow this outline. I'll give a preamble of the discussion, discuss some cases that we see here in Nigeria, talk about the management in detail in terms of the diagnosis and evaluation, treatment and follow-up, screening and prevention. And because we're in the era of COVID-19, I just have to make a brief note on that, and then I'll conclude. So when we talk about gastric cancers, it refers to malignancy of the stomach. We know that most of them are adenocarcinomas, but we definitely see lymphomas, carcinoid tumors, and leiomyosarcomas as well as GIST. But most of the discussion will revolve around adenocarcinoma, although I make a small footnote concerning GIST because we are seeing more and more of them in our environment. So we know that in 2018, gastric cancers were the 5th most common cancers worldwide and the 3rd major cause of cancer mortality in the world. Now, why this is important in resource-poor countries that even though the incidence is reducing in the West, it's increasing in low-middle-income countries, and the average of 1 million new cases per year. Generally, it's a very poor prognostic cancer with case fatality rate of up to 74%. But for every new case that we're seeing in the world, 7% of them are occurring in low-middle-income countries like Nigeria and Pakistan, and there's a higher case fatality rate of up to 90% in those countries. So it's a cancer of dismal prognosis. Now, again, when we're talking about resource-deprived environments, we look at the fact that there are things that are related to manpower, materials, machinery, mechanisms, money, and there's actually no time because there are other priorities with the government. And so we have challenges in managing these patients because we don't have access to happens. There's a management of these patients. As a general surgeon, I practiced in Nigeria. For a population of about 210 million people, we only have about less than 100 people who can do GI endoscopies and have access to the equipment. So we have manpower shortages. We have lots of issues concerning access to treatment, and that makes management very difficult. So I'll quickly talk about the case presentation. So the first patient was seen in 2016 in April, with a 5-year-old female who had complained of dysphagia and weight loss with anorexia. And the endoscopy I did then showed that she had a proximal gastric tumor, and the fund was encroaching the cardiac, and it was classified as serous type 3. And the histology came out as a moderate adenocarcinoma. And on CT scan staging, it was reported as stage 2B. So that time we started on therapeutic chemotherapy using ECF, that's equipuzine, cyclophosphamide, and 5-fluorouracil using the MAGIC trial, 3 courses pre and post-operatively. Now, at surgery, we decided not to do a total gastrectomy, which is what would have been recommended in Western guidelines because of the nutritional consequences of total gastrectomy we see in our environment. So we decided to be a bit novel, doing a proximal subtotal gastrectomy, in which we now left the distal gastrum and anastomosed it using staplers to the rest of the esophagus. So these are pictures showing the mobilization of the stomach and mobilization of the GE junction. This is the tumor in my hand, and we're trying to mobilize, getting tumor-free margins prepared to resection. This is the specimen resected, and I must admit that it was actually a D1 gastrectomy. As at that time, I wasn't too comfortable doing D2 gastrectomies, and then with the angle of the stapler being placed in the esophageal part of the specimen of the remnant esophagus, and then placing the stapler and firing it, and then reconstructing an esophagogastric anastomosis using staplers. So this patient did well post-operatively and had all our adjuvant therapy, but she developed bilateral ovarian masses with massive ascites about 18 months post the gastrectomy, but there was no evidence of local recurrence when we did surgery for a total abdominal hysterectomy and a bilateral salpingo-oophorectomy. However, she died. She refused the second-line chemotherapy and died 30 months post-operatively at home. So the second case is a 68-year-old male who was seen in September 2015. Then he had complained of feces or fecal and vomitus of 2 weeks duration, associated with preceding upper GI symptoms of 9 months duration. Upper GI endoscopy then revealed an infiltrating irregular obstructed mass at the greater curvature of the stomach with a lot of fecal debris. And when we evaluated, we found out that the patient actually had an infiltrating gastrocolic fistula from the gastric adenocarcinoma. So he went on to have an en-bloc multifascial resection of the fistula and the tumor. This is the laparotomy finding the stomach. This is somewhere in there. There's a distal part of transverse colon adherent to it, and there are also some station 10 lymph nodes at the splenic. So we had to do a subtotal distal gastrectomy. We had to do a extended right hemicolectomy and a splenectomy in order to get an RO0 resection. Thankfully, we had 16 lymph nodes harvested then, and then he had 6 courses of adjuvant chemotherapy. The last time we saw him was about 40 months post-op, and he's not had no recurrence, and he's doing very well. The third and final case was a 47-year-old male seen in 2017. He had complained of projectile vomiting, early satiety, and weight loss, and he had visible epigastric papillary mass and gastric peristalsis. CT scan has shown a huge antral mass. Although he had done a biopsy from another hospital that reported as gastritis, we suspected because it was a mucosal biopsy. But the CT scan reported that the mass was 12 by 8 centimeters and suggested an endophytic gastrointestinal stromal tumor. So we decided to go ahead to do a wedge gastric resection for him, and then this is the tumor being mobilized out of the stomach, and this is the specimen, the closure of the abdomen. So his pathology came out as a high-grade GIST, which was positive for c-KIT and desmin, and he was commenced on imatinib, mercilessly because of the high-grade status and risk of recurrence. Now, this drug is very expensive in our environment, but able to get it based on charity. And we still saw him last month in good state of health 3 years after the surgery. So in terms of the diagnosis and evaluation of patients with gastric cancers in our environment, we rely a lot on clinical features, and because we don't have so much access to GI endoscopy, sometimes we probably people tend to use barium meal as a substitute. But the main aim is to get endoscopic diagnosis. Of course, we have to stage the patient to find out if there's any evidence of local or regional extent. Bear in mind the fact that once gastric cancer is symptomatic, it's already either advanced or metastatic. Now, the role of tumor markers is quite questionable. And of course, we have to assess the patient's nutritional status and any comorbidities. Now, again, because we have a mixed audience, and there may be students here, I teach my students the mnemonics weapons to determine the symptoms of gastric cancer: weight loss, MSCs, anorexia, pain, paraneoplastic syndromes, evidence of obstruction, either dysphagia for esophageal obstruction, gastric obstruction with you, or colonic obstruction. And then we have nausea nodes, these famous Bechdel nodes, Irish nodes, and severity nodes. And of course, there may be evidence of spread for these patients. Again, I won't go too much about that because we have a lot to talk about. Of course, because we see a lot of patients coming with dyspepsia, we have to be aware of the alarm symptoms. Again, not to overflow that issue. So I teach my students to remember A, B, C, D, E of anorexia, bleeding, cachexia, dysphagia, and MSCs, because there's a higher chance of these patients having malignancy rather than just straightforward mucosal disease or gastritis. Of course, we need to consider risk factors of gastric cancers. Again, I teach my students to remember the word stomach. So smoking, cigarettes, taking smoked fish, or contain nitrosamine, some syndromes such as the hereditary gastric syndrome or Lynch syndrome, and even gastric surgery long term can actually be predisposed to developing gastric cancer in individuals. Exposure to talc, obesity, and immunodeficiency disease, and even men have predisposing factors to gastric cancers. Because blood group A is suggested to be predisposing factor, anemia, alcohol, and age. Of course, chronic gastritis is very endemic in our environment, and that's probably one of the reasons why we're having increasing incidence of gastric cancer in resource-poor settings. H. pylori infection is a very, very major factor there, and high salt diet has also been indicated. So these are some things that we look at in terms of symptomatology, alarm symptoms of dyspepsia, and possible risk factors. So I keep a clinical suspicion of gastric cancer. Of course, like I said before, endoscopy is the hallmark of diagnosis. We cannot do without it in many scenarios. Unfortunately, we have paucity of access to these facilities in resource-poor centers, and many people make diagnosis based on clinical judgment and imaging, such as barium meal, which is much more accessible than endoscopy. But of course, endoscopy helps us in tumor localization, and we need to take biopsies. And the more the biopsies, the higher the sensitivity and specificity Of course, the histology is very important, and the diffuse type is said to be very poor in prognosis, and we are seeing younger and younger patients in our environment, and these patients tend to have a diffuse histological type of tumors. Of course, we need to note that in submucosal gastric tumors, such as lymphomas, laminitis plastica, and leiomas, as well as GIST, those 3 Ls, endoscopic biopsy may not be reliable if the mucosa alone is biopsied. So in those kind of patients, we really recommend a core biopsy going deep within a particular spot to get to the submucosal layer to get an appropriate diagnosis. So I mentioned again, over and over again, this challenge of endoscopy. These are some of the pictures that we see in our environments here. So like the first time I had to do endoscopy, all this setup, the monitor was from a different company, the insufflator was from a different company, the light source was a different company, the rack itself was fabricated. So it was a chimeric monster of endoscopy material that was brought together just to get something to use. And again, you can see this is another picture of me. This was taken in 2016, where we're using a look-through endoscope, where we couldn't even display the picture on a monitor to see into the patient's stomach and esophagus for suspected gastric cancer. Of course, this is technology of the 1980s, which we still find use in some centers in Africa. Although people are able to adapt a camera head to be able to project the images on the screen, but again, we are seeing desperate measures to get some form of endoscopic diagnosis for our patients. So these are challenges that we can get to see in resource-poor settings. Now, again, even with that, we are seeing more and more cancer and upper GI cancers with endoscopies. In a study I did with some of my colleagues in 2017, we reported almost 20% of our upper GI endoscopies being malignancies, which is quite scary. And a lot of them had chronic gastritis, which in some scenarios can actually be a precursor to malignancy. There's metaplasia and dysplasia. And there's was also a high H. pylori positive rate. So we have issues concerning the prevalence and diagnosis of upper GI cancers in our environment. Now, again, quickly to staging. We know that the ideal is to do a CT chest, abdomen, and pelvis, but this is far out of reach of many people in resource-poor scenarios. And many people make do with ultrasound scan and a chest X-ray. Of course, we don't have ready access to endoscopic ultrasound, even though that's the ideal modality for staging the T and the M status of the tumor. And forget about PET CT scan. Most of the time, it's possible that we're understaging many of our patients in that light too. Now, there's this question about the role of staging laparoscopy and cervical tumors. It will make sense to do staging laparoscopy in our environment because we are seeing more and more patients with diffuse cervical type, which has a high propensity for peritoneal metastasis. Unfortunately, laparoscopy is not already available in low-middle income countries. And when I do laparoscopy for our patients, I prefer to do it in the setting of putting a feeding jejunectomy or a venting gastrostomy for patients who are very ill and cannot have resection studies. And I use the opportunity to appropriately do a peritoneal staging. So that's probably the role that we see for laparoscopy in gastric cancer. Is this where I was cut off? Hello?
Yeah, we can see the slide, Dr. Adimola.
Okay. All right, great. So I was trying to say that most of our patients come in with younger age, diffuse historical pathology, and with stage 3 and stage 4 disease. And unfortunately, stage 3 and stage 4 cancers have very dismal 5-year survival. They come with a lot of comorbidities, and they are typically malnourished. So these are some of the issues that we tend to see in our patients. So in terms of treatment options, we know that endoscopic mucosal resection is the ideal for T1A, N0, M0 tumors. Unfortunately, we don't have access to that, and many of our patients don't even fit that criteria. Surgery is the mainstay of treatment for our patients, and it involves around a tripod of gastrectomy, appropriate lymph node dissection, and appropriate GI reconstruction. And it could be radical or palliative, depending on the patient's presentation. Of course, we had a wonderful talk about minimal invasive surgery in esophageal cancers, and this is becoming increasingly applied in gastric cancers. Of course, we don't really have ready access to that in resource-poor settings. We depend more on open surgeries. Of course, chemotherapy is a very important tool in management of these patients. Radiotherapy has some controversies, and then I need to mention quickly about targeted therapies. So again, I know that it's popular to see European and Western guidelines for this, but it doesn't really fit to our own settings. And so the NCCN developed a harmonized guidelines for low-middle-income countries like Sub-Saharan Africa, which is what we tend to follow. And this has been endorsed by many of the governments in Africa. So for gastric cancers, they recognize the fact that even though there may be access issues, we need to find out whether there are any alternatives that will be cheaper for our patients. And so I really subscribe that we look through these guidelines to help in resource-poor environments. Now, like I mentioned before, radical surgery, especially due to gastrectomy, and adjuvant therapy is the mainstay of care. Of course, there's controversy about whether to use radiotherapy for our patients. In the Americas, they use a lot of radiotherapy for our patients. But in Africa, we have little access to chemotherapy and radiotherapy, and surgery is usually the mainstay of treatment too. So again, just for the students that are in here, for those who are interested, for intestinal type, we tend to have a shorter margin of 5 centimeters for R0 resection. Whereas if it's a diffuse type, we tend to get wider margins at least 8 centimeters to prevent issues of recurrence. And the reconstruction typically is either the endocyte gastrojejunectomy or a Roux-en-Y gastrojejunectomy. I typically tend to also do a brown anastomosis distally between about 40 centimeters from this gastrojejunectomy to prevent reflux. So that, because we have a lot of patients coming in with bile reflux after surgery without a brown anastomosis. So I typically put a brown anastomosis for my patients. Roux-en-Y, I do it occasionally, but for most of the patients who are sick, it's probably faster to get this done. Again, we don't have access to staplers for this anastomosis, so most of them are done hand-sewn. Although for the patient that I presented with the proximal tumor, we had access to staplers for that patient because it made the surgery quite easy to undertake. Now, the lymph node dissection, again, the standard is to do a D2 resection. We know that D1 involves perigastric lymph nodes from station 1 to 7. The D2 is from station 8 to 14. And we need to know that whenever there's the station 10 is actually a very important lymph node, because once it's involved, we have to consider doing a splenectomy, like the second case presentation that I mentioned there. And most experts have agreed that having at least 15 lymph nodes is important for staging and for prognosis in our patients, and it's a mark of adequate surgery. Now, like I mentioned before, open surgery is much more invisible, and surgical volumes are very important. We know that there are more complications with D2 resections, but it has a lower incidence of recurrence and a longer disease-free survival. Like I mentioned before, most of our patients have come in with stage 3 and stage 4 disease, especially with emergencies. They come in with perforations, they come in with bleeding or fistula, and we could actually do palliative gastric resections without lymph node dissection for those kind of patients in terms of palliative surgery. Of course, gastrojejunectomy can be done for our patients. We don't have access to endoscopic stenting to leave GO. And I've mentioned before that for patients who are very ill and have cancer cachexia, the probably best form of palliation would be to do a feeding jejunostomy and probably add a venting gastrostomy to allow the patients to be able to drain gastric juice. Surgery complications are just skipped that because of time. Now, we know that chemotherapy can improve survival, but we have issues with access to chemotherapy because of cost, patient suspicion, toxicity, and even fake drugs too. But we know that chemotherapy has been known to improve survival by up to 5 to 10% in many series. And we're trying to have certain initiatives to make chemotherapy accessible to our patients, subsidized by grants, international grants across sub-Saharan Africa. And many of these chemotherapy agents that have been listed here are drugs that we use for gastric cancer. So we're hoping that in a couple of months or years' time, they will have better outcomes in terms of overall survival for our patients. But we know that only 10% of our patients will receive any form of cancer surgery treatment, including chemotherapy. Now, I won't mention about the MAGIC trial because there's no time, but just to mention that the MAGIC trial brought in for ECF, which is 5-FU cisplatin and etripsin, as a standard of preventive care. But recently now, the FLOT combination therapy is the mainstay of perioperative chemotherapy for the patients, where we use 5-FU, oxaliplatin, and docetaxel. Again, these are very toxic agents, and they don't come too cheap. But for patients who can afford it and are fit, we tend to give them now in place of ECF. Now, for those patients who come with stage 4 disease, where the aim is palliation, we do not give those 4 drugs because of the toxicity. So we prefer to give a doublet therapy, usually 5-FU oxaliplatin for fit patients. And patients who are not so fit, we give capecitabine, Zeloda, for failed patients. Again, there's always been this issue of trying to use HER2 inhibitors like trastuzumab for our patients. But it's not readily available and it's very, very expensive. And so we don't usually put it as part of our routine medication for our patients. Now, I know that there is this concept of classifying gastric cancers based on immunohistochemistry and phenotype, and that may have prognostic values in terms of targeted agents. But we found out that most of the targeted agents are not useful in our environment. They're just probably modest few months benefits with using HER2 inhibitors. And many of the new agents like ramucirumab have been shown to be negative giving us negative outcomes in trials like the Rainfall, Rainbow, and Regal trials. So we don't really typically use them in our settings. And radiotherapy, again, I feel that the most important role for radiotherapy will probably be for patients who had less than a D2 surgery. But again, it's not already available in our environment. And there are a lot of trials that have been conducted, and those are the Top Gear and the Crisis trials to actually define the appropriate role of radiotherapy in our management of patients with gastric cancer. So it's still an evolving field. Now, again, the issue of prevention is probably for public awareness, but we know that there are certain protective factors like the 3 Fs, fruits and vegetables, fibers, and folic acid can actually help. But again, we don't have access to screening of those patients who have pneumoplastic conditions in our environment. Almost the last slide. So we know that there are certain COVID-19 challenges now, and the lack of access to endoscopy, the fear of acquiring the infection in the hospitals that cause delayed presentation. We're unable to make diagnosis for our patients. We're already bad before, now becomes very worse. We're not thinking of doing more chemotherapy for our patients and less of surgeries, and we are reducing elective surgeries for our patients, and most of the people that are getting done for gastric cancers are those coming in emergencies. One final gist about GIST anyway, because we are seeing more and more GIST patients now, and we found out that these patients are actually very more pleasant to manage because they are relatively fit. There's a targeted agent that works for them, and they tend to have a better overall survival compared to adenocarcinomas. And so we just need to watch out for these patients because they have a better outcome. So in conclusion, there's a rising incidence of gastric cancers in resource-poor environments. We have a high case fatality and it's generally poor prognosis. And this is because we have challenges in accessing resources that will manage these patients. And we need to understand the fact that protocols have to be tailored to realities on the ground. And that's why we're using more of the NCCN harmonized criteria rather than the Western criteria for our patients. Thank you so much for your attention. And I'll be happy to take questions later on.
Thank you, Dr. Ademola. That was an excellent overview of the management of gastric cancer. And also, thank you for sharing the Nigerian experience. We will take some questions and comments at the end. We're running short of time. I would like to thank you, and I would like to proceed to the next speaker. Professor Amir Nisar from Dubai. I think, Professor Chima, I think he's not joined us till now.
I think there are some issues from joining from there. So we can go ahead and ask Raza to start his presentation.
Yeah, I would now like to invite Dr. Raza Saeed. He is the chief of surgical oncology at the Patel Hospital in Karachi, and he is going to give us a short talk about research project and global surge and the COVID surge week study. So, Dr. Raza Saeed, can you please take over? Raza, are you there? Go ahead.
Thank you very much for allowing this opportunity to present very briefly this study called COVID Surge Week. This is myself and Dr. Ahmed Uzair Qureshi from services who are leading this project in Pakistan. And this is an attempt to recruit more centers for this study that will start in October. Now, there is an urgent need to understand the outcomes of COVID and infected patients who undergo surgery. And the collaborative itself was developed to explore the impact in these patients. So they did a modeling study, presented guidelines, as well as there are two main studies that are already in progress and almost about to close that have been done by this collaborative. One was the COVID Surge Cohort study and COVID Surge Cancer study. The modeling study essentially looked at how many elective surgeries were cancelled worldwide due to COVID-19 pandemic, and it published itself. And after that, a lot of debate occurred because of the impact of the pandemic. And then the collaborative issued guidelines for surgical care during the pandemic, which was also published. The first analysis of COVID Surge Cohort included patients from Pakistan, and we are very proud for the contribution from our country. So 24 countries, 235 hospitals, and more than 1,100 patients with COVID diagnosis were treated. And basically they showed that the 30-day mortality for patients who had perioperative SARS-CoV-2 infection is 24%, which is very high, and the risk of pulmonary complication is almost half. The COVID surge cancer study protocol itself included all patients who were operated for cancer during the 3-month study period of the pandemic, and also included patients who were supposed to undergo surgery but could not undergo surgery because of the pandemic. So follow-up for those patients is going on for now 6 months, and it will also complete in September. And the initial publication from the initial analysis is already written up and has been submitted, so we will be hearing about it soon, inshallah. Now, the Global Surge and COVID Surge Week study is the next step of these studies, and we'll see what the aims are. But it includes all hospitals, regardless of whether they have COVID patients or not, and all patients from the hospital, all specialties, surgical specialties, and the data collection blocks is in 1 week period, and there can be multiple data collection blocks from the same hospital from same multiple number of specialties. So aim is to determine the optimal timing of surgery following the SARS-CoV-2 infection, and assess key global surgical indicators such as post-operative mortality. All hospitals can participate, including even hospitals that do not have patients infected with SARS-CoV-2. Obviously, there are many countries who are beyond this phase of the pandemic. All patients from all specialties undergoing a surgical procedure done in an operating theatre are eligible to be included. All collaborators who will contribute data will be included as PubMed citable co-authors, and they can cite this as their work. Not only that, once these are very high-profile studies, once these studies are kind of cited over and over again, even the citation index for each of the contributing authors increases. So it's a very good opportunity to be involved in this large collaborative group, which is going to have a huge output of very high-profile studies. So this study basically will be looking at the diagnosis of SARS-CoV-2 in one group who have the diagnosis confirmed preoperatively. The second group is patients who have actually acquired this infection in the post-operative period, and the third group is those patients who do not have SARS-CoV-2 diagnosis either preoperatively or after surgery. And then comparing outcomes, primarily 30-day mortality, but other secondary outcomes like in-patient mortality, post-op pulmonary complication, DVT, as well as any cleft end-of-grade complications. So this study will have actually launched almost a month ago, recruiting centers, and there are a large number of centers, almost 1,200 centers from all over the world have been included, and this includes almost 60 collaborators from Pakistan so far, and we are hoping that we can interest all of you to take part in this. Once we register the teams, then the logins for RedCap, which is a data collection software, will be issued in September. And then in October, 7-day data collection periods will start. A hospital can have more than one data collection period, followed by a 30-day follow-up. So hopefully by end of November or mid-December, the data should be complete. How do you get involved? The registration form is link is is.gd/surgeweek. I will, or the globalsearch.org/surgeweek. Principal investigator should get start working to get local approval, and that local approval from the hospital can be an audit approval by head of department, or if there is an ERC or IRB, which are Ethics Review Committee or Institutional Review Board, then you can apply for an exemption for review because it does not involve any direct interaction with the patient. And this has to be completed prior to the study, and we have like almost more than a month to achieve this. Then identify specialties which are going to contribute data, make mini teams of up to 3 individuals for each specialty, and then identify data collection window for multiple teams. The logins will be issued in September, and inshallah the data collection will start in October. More details about the study are available on the website. We have, alhamdulillah, been able to achieve, get the approval from the National Bioethics Committee for this study. So anyone who registers for the study gets in touch with us, and we will forward this approval to you, and you can use this approval in support of your application to get local approval from your institution. Dr. Ahmed Hussain Qureshi is my co-lead for this project, and anyone can contact either Dr. Qureshi or myself if there are any doubts about the study. The collaborative authorship, as I explained, the study goes under the authorship of COVID Search Collaborative, and in a supplement, all the contributing authors contributed to data will be part of the authorship group, and this is PubMed citable, and obviously these are going to be high profile publications with multiple citations. So this is an opportunity to get really yourself better on the authorship ladder. So you can join search.org/searchweek. If there are any questions or concerns, you can contact me through the SOSPK website or Dr. Ahmed Hussain Qureshi. We will be more than willing to help you guys. Please join us, and more data that we produce or contribute to Pakistan that will help policymakers make decision on, and we can actually contribute to this. Thank you very much.
Thank you, Raza. That was very, very informative. I think a lot of our institutions are already joining, and at least 2 groups from my own institution have signed up, done the initial sign up, and we shall be in touch with you soon. So I think we've gone a little bit over time, and I would like to avail this opportunity to thank everybody, and especially our speakers, Dr. Ademola Adeyeye from Nigeria, and Dr. Bilal Umair from Rawalpindi, and Dr. Raza Saeed for such elaborate presentations and very, very informative. I think we had a very useful session today, and very, very practical based sort of a session. And my special thanks to all the audience. I think we had some audience, some participants, some people participating from Nigeria also. So I would like to thank them especially. And thank you, Professor Muhammad Arshad Cheema, for joining us, our founding president. And